Hello, my name is Paul Gallagher and I'm going to act as your moderator for this webinar today. I'm a general surgeon based in Northumbria with an interest in upper gastrointestinal surgery. That's the area that involves the treatment of conditions affecting the esophagus, stomach and biliary tract. I'm also the head of School of Surgery for the northeast of Cumbria with responsibility for the management of all our surgical training programs in the region. We'd like to thank the Royal College of Surgeons of Edinburgh for the opportunity to present this webinar today. This is one of a series of webinars provided by the Regional Surgical Advisors of the College, or RSAs. There are over 40 RSAs who are consultants and college fellows who provide advice and support at a local level across the United Kingdom. You may well have met one of us at your local educational event or careers evening at your medical school. Please find more details about us on the RCS Ed website. Today's speaker is Cynthia Borg. Cynthia is a consultant surgeon at the University Hospital Lewisham. She specialises in bariatric and metabolic surgery and benign upper gastrointestinal surgery. She has been an RSA for several years and is also a council member of our national associations for upper gastrointestinal surgery and bariatric surgery. The topic of today is dysphagia due to dysmotility or tumour? What do I do next? We'll be using a poll at the start to warm you up with some questions. Then during the talk, you can use the Zoom question and answer facility to pose questions to the speaker. Please see the Q&A button at the bottom of your Zoom screen. We will save the questions until the end of the presentation and try to answer the most popular questions. Please vote with a thumbs up symbol beside the questions you would most like answered. I'll now hand over to Cynthia.
Thank you very much, Paul. Thank you for the introduction and thank you all for joining us today. Hope you are all safe and well. On your behalf, I'd also would like to thank the college, especially Mike Silva for coordinating all this, as well as Ryan and Heather, who are also from the college and are working behind the scenes. So, the topic for today, as Paul said, is dysphagia. And we're going to be talking about the causes of dysphagia, its evaluation and the management. So I'd like to introduce two cases in order to be able to delineate these investigations and the management that we're going to do. The first patient is Mr. AB. He's 67 years of age and he comes to endoscopy with a history of progressive difficulty in swallowing that started 3 months back. He recalls it very vividly and first says that he choked on a piece of steak about 3 months ago. Since then, this has been getting progressively worse and he can only drink soup now. He is a lifelong smoker, having smoked from the age of 16. His wife is with him. She's very concerned. She's concerned because she has to cook twice. She has to cook her own dinners and she has to do soups for him. She's also very concerned because she can see that her husband is losing weight. He's lost 7 kilos over the last 2 months. And she also very recently noticed a lump in his neck and she points to the supraclavicular region. The next patient is Miss X. She's 35. She's recently married. You see her in your outpatients clinic complaining of reflux. When you're asking the questions, she's also has a long history of difficulty with drinking liquids and also with eating solids. Her husband, who's not with her for the clinic, says that she's waking him up at night very frequently with coughing. Now, how are we going to investigate these two people? We're going to take a history, we're going to listen, and we're also going to ask some questions. The first thing we're going to ask is about dysphagia. Now, what dysphagia is a difficulty or inability to swallow. We're going to ask the patient whether it's progressive or whether it's intermittent. And what are they unable to eat or drink? This is also going to be very important for our management. Because if we're seeing a patient like Mr. AB who's telling us that he's barely able to drink, then we need to do something while we're doing our urgent investigations to make sure that he's well fed and well hydrated. We will ask about odynophagia. Now, odynophagia is pain on swallowing. And when patients have odynophagia, usually they have either an inflammatory or an infective process going on. Lots of patients come and tell us about reflux. However, reflux is a very vague symptom, and we really need to ask them what they mean. Some patients turn up in A&E with crushing chest pain, having an MI, and saying that they have reflux. So we really need to take an appropriate history of the pain. What do they mean? Regurgitation. Regurgitation is effortless fluid or food coming back up. Now, regurgitation usually happens when either the patients bend or when they lie down in bed. So we also, an important question is, how many pillows are they using? Are they propping up the head of the bed? The other thing we need to ask is about chest symptoms, about chest pain, because that might be an indication of esophageal spasm, and also about cough and recurrent chest infections, because those might be a sign of silent aspiration. Then we proceed with the examination. We really need to check their weight. We check for signs of malnutrition. We look for metastatic spread, as well as signs of systemic disease like systemic sclerosis. Now, when we're taking a history, when we're examining the patients, we must have a differential diagnosis in mind. Yeah. So, in terms of causes of dysphagia, we have causes that may be in the lumen, intraluminal, and here we've got a low power cross-section of the esophagus. So intraluminal problems can be things like foreign bodies or a food bolus. But remember, a food bolus may be a sign of some intramural narrowing. So it is not normal for a 67-year-old to say, oh, I'm choking in my food. Yeah, that's not normal. That probably is an indication of an obstructing lesion, either in the wall or extraluminally. So neural causes can involve the epithelium, this lining here, which in the esophagus is usually a squamous epithelium. Most commonly, we get complications of reflux, things like severe inflammation or peptic strictures that might give our patients intermittent dysphagia, or else malignancies like squamous or adenocarcinoma that we will deal with and talk about in a bit more detail later. We also have the submucosa here, where we can get the motility disorders involving the muscles or submucosal tumors. Then we have extraluminal causes, things like compression from lymph nodes, from tumors, from vascular structures, as well as things like hernias. Remember, there can be a proportion of our patients that have psychological issues, and that you investigate them and you don't find any physical cause of their dysphagia. But obviously that is a diagnosis of exclusion. So today we're going to be emphasizing mainly on these malignant lesions as well as the motility disorders. Esophageal cancer usually presents in the 6th to 7th decade. It is more common in males. Usually there's a 3:1 ratio. It often presents late and hence may be associated with a poor prognosis. And Cancer Research UK actually quotes the 5-year survival as about 15%. We've got squamous cell carcinoma. That's the commoner one of the two worldwide, especially in the developed world. Usually it's in the upper 2/3, most commonly in the middle third. And there are risk factors like alcohol, smoking, dietary factors like things like lack of vitamin C, and carcinogens like the nitrosamines. The commoner tumour in the UK and certainly in the Western world is the adenocarcinoma. It's usually found in the lower third of the esophagus, and the risk factor certainly is reflux, Barrett's esophagus, obesity, and also smoking. Now, with regards to primary esophageal motility disorders, here we can see a normal swallow. So up here, we've got the upper esophageal sphincter, high pressure zone, about 100 millimeters of mercury. Then we give the patient something to drink. This is a manometry. So we give the patient something to drink, and here you can see the bolus move, usually with a speed of about 5 centimeters per second, until it reaches another high pressure zone here, which is the lower esophageal sphincter, which relaxes, allowing the bolus to go into the stomach. With regards to motility disorders, we've got the classical achalasia. So with classical achalasia, what we have is a failure of the lower esophageal sphincter there to relax. So what happens is that the body of the esophagus tries to pump harder and harder. It hypertrophies, but then in the end, it gives up and can be atonic. Then we have got some other conditions which involve hypercontraction of the esophagus with big waves, and the patients might get things like chest pain. We also can get uncoordinated contraction of the body with diffuse esophageal spasm, or a hypocontraction of the body. And that's hypocontraction is very commonly seen with reflux esophagitis. It's like an egg and chicken situation. What came first, the reflux or the hypocontraction? Achalasia is the one that is most commonly studied, and the one that is, that we're going to talk about today as well. There are other disorders that secondarily may cause muscle problems. Chagas disease, it's an infection, a protozoan infection that's common in South America. There are other diseases that affect muscles, like scleroderma, that can give rise to motility disorders. And there's also what's known as pseudoachalasia, which is a tumor of the cardia that can mimic achalasia, both in terms of symptoms, but also, more worryingly, when we do manometry. So, in terms of investigation for dysphagia, our gold standard investigation is going to be an upper GI endoscopy. In this test, which we can do either with local anesthetic, with throat spray, or with an intravenous sedative, with conscious sedation, we will be able to assess the lining of the esophagus, but also we'll be able to do biopsies. So in terms of NICE says that we should offer urgent direct access endoscopy within 2 weeks, what we call a 2-week wait endoscopy in patients with dysphagia, any age, or if they are aged 55 or over, with weight loss and any of the following, either upper abdominal pain or reflux symptoms, or else dyspepsia. Again, we have some other investigations that we might use, contrast studies, cross-sectional imaging, we've already discussed the manometry, and also some other investigations, specialist investigations that we might need in terms of tumor staging. So this is Mr. AB. He came for his endoscopy. Here we can see a raised area very close to the gastroesophageal junction, which is here, and at the proximal end of this raised area, we can see an ulcerated area here. We biopsy, we take multiple biopsies, and the histology was an adenocarcinoma. While we're waiting for the biopsies to be processed, we send Mr. AB for a CT scan of his neck, chest, and abdo. And what we can see here is the esophagus, which is dilated, which has got an eccentric lesion there. Here on the coronals, and there we can see it on the sagittals. Again, one must notice where the esophagus is lying in terms of the other structures in the chest, and that determines the spread, the easy spread of the esophageal cancer to the rest of the chest organs, and also the difficulties that we might experience in actually removing surgically a tumor of the esophagus. Now, this is the TNM classification. You don't really need to know it, but if the tumor is very, very superficial, there might be some options other than surgery that we can offer to the patients. So, this is Miss X's endoscopy. So we can see that it's completely different now. The mucosa looks perfectly normal and healthy. We can see the GOJ there. And when we retroflex, when we're in the stomach and look back on ourselves in the cardia, as we're doing here, there are no lesions, no tumors, and that excludes that pseudoachalasia that we were talking about. So what are we going to do? We're a bit stuck with Miss X, what's going on? So we sent her off for a barium study. So here we can see the esophagus is dilated. So the esophagus usually is quite small in diameter, certainly not as much as wide as a vertebra, which you can see here. You can also see flocculations and residual food there. What we can also see here is an air fluid level in the esophagus that we shouldn't see. And we can also see the tapering of the lower esophagus in like it's called a bird beak appearance. And here we can see the fluid going slowly through the GOJ. Again, another feature that is missing on this upper GI study and is quite typical in cases of achalasia is the absence of a gastric bubble. So these features, the fluid level, the bird beak appearance, and the lack of gastric bubble are quite typical of achalasia. In order to prove that it's achalasia, we also send her off for a manometry. And here we can see failure of relaxation of the LOS, as well as a absence of peristaltic waves when she's given boluses to drink. So, when we are managing patients with dysphagia, we need to, first of all, take care of their nutrition, to try and prevent aspiration, and because that's going to obviously harm their chest, give them chest infections, especially if we're thinking of operating on them, and then come to definitive management. In terms of achalasia, we can try Botox. Usually it only gives a temporary relief of the symptoms. So what we're trying to do in order to manage the achalasia is to try and relax that lower esophageal sphincter. So we can try Botox, especially in patients who are elderly and who would not withstand anything else. We can try endoscopic dilatation with an achalasia balloon. Usually it's very high pressure for about 3 minutes. Or else we can do a Heller's cardiomyotomy. These days we do it laparoscopically. We dissect the hiatus. We do a long myotomy on the anterior surface of the esophagus and take it a couple of centimeters onto the stomach. Also of note, achalasia does confer a small risk of esophageal cancer long term. So some patients opt to have, say, annual or once every couple of years have an endoscopy just to check that they decrease the risk. In terms of esophageal cancer, when we're going to manage patients, we need to assess their fitness. Are they fit for a rather big operation? We also need to stage the disease. We've already talked about the use of CT scanning. We can also sometimes require PET, endoscopic ultrasound, fine needle aspiration, and staging laparoscopy. So in our gentleman, in Mr. AB, you remember that his wife had pointed out the supraclavicular lymph node. He had an FNA of that, and that showed malignant adenocarcinoma there. So when he was discussed in the MDT, the question that we always ask is, can the patient be treated with curative intent? And certainly, because this is a metastasis and classified as a distance metastasis, Mr. AB could not be dealt with a curative intent, but needed palliative treatment. If he didn't have that metastasis, and if the tumor was deemed curative, usually in tumors that are squamous cancer, especially in the upper third of the esophagus, most MDTs would recommend chemoradiotherapy. Sometimes either the MDT or the surgeon and the patient would opt for surgery. With adenocarcinomas, if they are very, very superficial, if they're T1A, one may offer endoscopic excision, but remember, with endoscopic excision, you're not going to take those lymph nodes, although the chances of having lymph node mets in T1A is small. Or else we can offer neoadjuvant chemotherapy followed by surgery. With palliative treatment, we try to control the symptoms and improve the patient's quality of life. And we can do that with stents, with laser, with palliative radiotherapy. In terms of surgery for esophageal cancer, we've already said that the esophagus lies in the back of the chest in quite a tricky position, surrounded by the heart in the front. We've got the ribs, we've got the vertebra, we've got muscles, nerves, big vessels going across. So it all depends about where the tumor is located and the surgeon's and the patient's preference. Certainly, we can't sort of stretch the rest of the esophagus down, so we need to use a conduit, usually the stomach, to go up to the chest. Sometimes the surgeon and the patient preferences are that they do offer open surgery, and sometimes if the skills, the facilities are there, then one can opt for laparoscopic or even robotic surgery. So in conclusion, there are several causes of dysphagia, but when you see a patient with dysphagia, you have to exclude malignancy with a 2-week weight endoscopy. Always think nutrition. How is the patient going to survive and to be well hydrated while I'm doing these tests? And remember, you're not alone. This is going to be, in terms of tumor management and even achalasia management, this is going to be in the setting of an MDT, a multidisciplinary team. Thank you very much. Any questions?
Cynthia, thank you very much for that thorough overview, where we've covered many things with the two very interesting case histories. The audience have come with lots of questions. And first of all, we'd just like to start with some questions about clinical assessment. So first of all, how would you differentiate reflux from regurgitation from the history, and maybe to describe what's the difference between reflux and regurgitation? Okay, so what most patients would mean by reflux is heartburn. So they eat something, and after a couple of minutes, then they start getting discomfort. It may sort of radiate up to their chest, and it may be accompanied by regurgitation. Usually with reflux, patients can take
over-the-counter drugs, things like antacids or sometimes even milk, and that gets better, and that can differentiate it from other causes of abdominal pain. Regurgitation is sort of effortless food or liquid coming up, usually to the mouth. Some patients also complain of water brush, sort of the acid irritating the back of the mouth, and sort of an acid taste in the mouth.
Thanks, Cynthia. Another clinical question, and first of all, a terminology question. What's the difference between dyspepsia and reflux?
Okay, so this dyspepsia is a sort of any abdominal pain that's associated with eating. So, you know, it's a sort of any pain that occurs after eating or that's associated with eating is dyspepsia. So sometimes even on GP referrals, you can see patients with dyspepsia and the patients end up having biliary colic. So it's, you know, you need to ask more probing questions in terms of what is triggering it. Is it being triggered with fatty foods? Is it being triggered with things like spicy foods, and then do the appropriate investigations.
So we need a thorough interrogation of the patient's history, really, to see what they mean by the term dyspepsia, because they might just have a vague sense of something not being right.
Exactly.
With esophagitis, when they get dysphagia, difficulty swallowing, what is the mechanism for that?
I think that's due to actually inflammation of the esophagus and ulceration. Sometimes you go in, have a look at endoscopically and say, my goodness, the patient has, what are these ulcers from? And you sort of biopsy, take lots and lots of biopsies, and they're all benign or reactive. You give them PPIs for 4 weeks. You go back down and check again, and all that is gone. So certainly sometimes with the edema, with the inflammation, that may trigger also a feeling of, you know, of food getting stuck.
Well, we're going to move on to some slightly more technical questions now about investigation. Mm-hmm. First of all, what is the significance of endoscopic ultrasound in diagnosis of esophageal cancer? From Malith. Thanks, Malith.
Okay. So, once you have a diagnosis with biopsies of esophageal cancer, then endoscopic ultrasound is very good to see the spread. How much has it invaded into the esophageal wall? How much has it invaded? Has it gone beyond the submucosa? Has it gone into the muscles? Has it gone into the things like the pleura, the pericardial cavity? What is also good with endoscopic ultrasound is that you can see the lymph nodes. Now, some lymph nodes on CT can be equivocal, as we're saying. It's usually associated with ulceration. With ulceration, you can get reactive changes in the lymph nodes. So with the EUS, it's very good because you can actually get fine needle aspiration of those lymph nodes. Also, CT is notoriously bad to see how much the tumor has spread into the muscles. So EUS, endoscopic ultrasound, is very, very good for that.
Thanks, Cynthia. And now a question about treatment. At what stage do we decide to go with palliative treatment for esophageal cancer rather than an attempt at curative treatment? Okay.
So certainly, first of all, the patient fitness. This is very, very important. You don't want to do a lovely operation, but then the patient dies. So you need to check the patient, to assess the patient's fitness, and check what the patient expects. You know, are there underlying conditions? Regarding the TNM classification, T4 means that the tumor has actually spread to the surrounding structures. So unless you're able to remove the tumour en bloc with the lymph nodes, then there's no real point to subject the patient to such an extensive operation if you're not getting an Arnold resection. Now, sometimes, despite all the staging, all our best intentions, we go in, we do a resection, and anyway find that it has spread beyond our margins, usually our circumferential margins.
Thanks, Cynthia. We've got a couple of minutes left, so I'm just going to move on to the patient with reflux. And there were some questions about the management of patients there. And what is the way or the mechanism that the esophageal physiology tests are done, just on a practical basis, for what the patient has to go through, first of all?
Okay, so usually, at least in our case, we would send the patient to a center, because it's very important that these tests that are so highly specialized are done in a center that sees lots of these, because even the reporting, it's not just, you just look at you get lots of results. So what they do first is pass a little tube, like a little NG tube, down the back of the nose and the esophagus into the stomach. And then there the tube has little side holes, that they can perfuse fluid through. And what happens is that they ask the patient to swallow, and then ask the patient to drink. And they usually do 5 dry swallows, 5 wet swallows, and then check the motility and like that trace that we had, the pressures, and hence the pressures. Once they find where the gastroesophageal junction is, where the lower esophageal sphincter is, then they would be able to put the pH probe, and the pH probe usually is for 24 hours. There are some instances where we can also do manometry for 24 hours in patients with things like diffuse esophageal spasms, or where the symptoms are intermittent, so that we try and catch the symptoms. The pH study also, they have a little box which they can press, so that when they have the symptoms, like when a patient is experiencing what they think is reflux, they press the button, so that when they're reading the report, they can see whether that symptom correlates to what they are seeing on the actual trace.
Thanks, Cynthia. And then the final question, after you've done an endoscopic dilatation, do the patients suffer from reflux after you've got rid of their difficulty swallowing in, say, a patient with achalasia?
So certainly, yes, that may be the case. Yeah, so you try and stretch it and weaken it. So with dilatations, usually the patients, that can happen. The other thing that can happen also is that you overdo it and you actually perforate the esophagus, perforate the mucosa as well. Some patients with dilatation need more than one dilatation. Then if you're going to do a Heller, actually most surgeons laparoscopically would do a small fundoplication. So you're releasing the muscle, but then trying to prevent or circumvent that they have lots of reflux. So most people do a sort of door and anterior fundoplication, certainly. That's what I usually do in most of my patients.
So they'd wrap the stomach over the esophagus to prevent reflux. Thank you, Cynthia. Now, we've got another 21 questions, but unfortunately no time to answer them. So your talk's generated an awful lot of interest. Cynthia, thank you so much for a really interesting overview and for answering the questions. Again, thank you to the Royal College of Surgeons of Edinburgh for hosting this. Can I take this opportunity to mention that our next webinar is next Tuesday, the 28th of April at 4 p.m. And the title is "My Patient Has a Pulsatile Lump. How do I approach this problem?" by Mr. Peng Wong. And as a reminder, along with all previous and future webinars, today's session will be recorded and available to watch on the college website. Again, thank you everyone for joining us, and thank you to Cynthia and the Royal College.
Thank you.
Hello, my name is Paul Gallagher and I'm going to act as your moderator for this webinar today. I'm a general surgeon based in Northumbria with an interest in upper gastrointestinal surgery. That's the area that involves